on Professor K. Krishnamoorthy Golden Independence Conference Commemorative Oration 2020. For that, I welcome Dr. Rajan C.S. from Bangalore, Dr. Ashok Godhi from Belagavi, Dr. Gandhi Bhaskara Rao from Rajamundry, Dr. Rajkumar Jano from Jaipur, Dr. Sulfikar M.S. from Trivandrum, and Dr. Lakshman K. from Bangalore. First and foremost, I welcome Dr. Rajan C.S. to orate Professor K. Krishnamoorthy. Welcome, sir.
Yeah. Good evening. May I share my screen, please? Good evening, everybody. And thank you, ASI, for giving me the opportunity to introduce my former teacher and guru, Professor K. Krishnamoorthy, in whose name we have the Golden Independence Conference Commemorative Oration. Dr. K. Krishnamoorthy was born in December of 1912 to be the son of a prominent ophthalmologist, and he had a very distinguished medical course of study at Mysore Medical College. At a very young age, he produced a paper on the volvulus of the stomach, and this was accepted into the Indian Journal of Surgery, for which they gave him a membership even before he became a postgraduate, had his postgraduate qualification in surgery. After the Second World War, he went to France, where he secured his MS in surgery, and then went across the channel to UK to get his fellowship from the Royal College of Edinburgh. He came back in 1950 to the Victoria Hospital and has worked in each of the government hospitals of Karnataka, at Victoria Hospital, Bangalore, Mysore Medical College, Mysore, and at Karnataka Institute of Medical Sciences at Hubli. In 1962, he came back to Bangalore and was the founder vice chairman of the Surgical Society of Bangalore. He also did many academic and organizational roles, being the organization secretary for ASICON 1970, the chairman for ASICON 1985, and the patron for ASICON 1997, all of which occurred at Bangalore. He was the first surgeon to be awarded the Lifetime Achievement Award of the Surgical Society of Bangalore. Unfortunately, we lost him on the 12th of August, 2002. After his death, the Surgical Society of Bangalore named the Medical Library and Information Center after his name. The Golden Independence Conference commemorative oration in ASICON was started in memory of the 50th ASICON that was held in Bangalore, where Dr. K. Krishnamoorthy was a patron. And we automatically chose his name to be the name for the oration after that conference. It is my honor and privilege to present this introduction to Dr. K. Krishnamoorthy, the background behind his oration. And I now hand over to Professor Ashok Godhi to introduce our orator for this evening, Dr. K. Lakshman.
Am I audible? Am I audible?
Yes,
sir, you are.
Yeah.
Okay. It's my honor and pleasure to introduce my good friend, Dr. K. Lakshman. Dr. Krishnaswamy Lakshman was born in January 1954 and completed his medical studies at the Bangalore Medical College in 1976. He went to UK and got his fellowship of the Royal College of Surgeons of England and Edinburgh by 1982. After working a couple of more years there, he did a fellowship in nutrition in Boston, USA, and returned to Bangalore in 1986. Here, he has established himself to be a clinically very efficient GI and laparoscopic surgeon with very good skills. Dr. Krish Lakshman has his forte in surgical academics and is at the very forefront of information technology as it has evolved into our daily lives and into the practice of our surgical art. He has spent all his spare time involved in very important co-curricular activities like setting up of the first medical digital library in Bangalore. He has set up the Clinical and Laparoscopic Skills Center at Bangalore Medical College, the first of its kind in Karnataka. He was the prime force and support in fully digitizing the registration at ASICON 1997. Besides this, he has been the convener and quiz master for the now very popular National Surgical Quiz. As the director of academics at Sagar Hospital, he has put into place the best surgical department of DNB stream with a 100% pass record and innumerable articles and publications. He has delivered many orations and invited lectures, written several key chapters in books related to surgical nutrition, patient safety, computers in medicine, ethics, clinical audit and research, and HIV with its implications for the surgeon. He has written a book, Evidence-Based Surgery and Research Methodology, aimed at the proper initiation of surgical postgraduates into the processes of their thesis writing. Currently, he is the chairman of the Bone Marrow Registry Committee and is setting up the much-needed donor registry for the country. Dr. Lakshman is a very down-to-earth, friendly, and popular colleague. Surgeons look forward to his words of principled wisdom at the surgical meetings and gatherings. Into his busy schedule, he fits in his passion for high-altitude trekking and has trekked Everest Base Camp in the Himalayas, besides conquering the Kilimanjaro peak in Africa. Carnatic music is his love too. In his early days of surgical career, Dr. K. Lakshman has interacted in many a positive way with late Dr. K. Krishnamurthy. It is but apt that the Association of Surgeons of India has the privilege and honor to invite Dr. K. Lakshman to be the Professor K. Krishnamurthy Golden Independence Conference Commemorative Orator for 2020. Here, I present Dr. K. Lakshman to the audience. Thank you.
Thank you very much. If I may share my screen, please. Am I audible? And can you see my screen, please?
Yes.
Thank you. Good evening, ladies and gentlemen. It is indeed an honor and a privilege to be delivering the Professor K. Krishnamurthy Oration 2020. I am deeply thankful to the President and the EC of Association of Surgeons of India for giving me this opportunity. It is indeed an honor doubled because I had the good fortune of knowing Professor Krishnamoorthy very closely from the time I came back to practice in this country in 1986. It was customary for both of us to go together with another senior surgeon called Dr. Gunashila very regularly every month to the meetings, clinical meetings of the Surgical Society of Bangalore. During those trips, I've indeed had tremendous pearls of wisdom, learned a lot about the science and art of surgery and about being a good surgeon from Professor Krishnamoorthy. It is really fortunate that I now have the opportunity to talk in an oration named after him. I'm very sure that he would have completely agreed with the choice of this topic that I have made, because he was the quintessential mentor in surgery. Many people who have gone under his tutelage are very, very happy about the way he treated them. And surgical mentoring is something that is also very important for all of us, seniors and juniors, to ponder together, because I do believe that while many mentoring programs do exist in this country, that we need a lot more of them. And so I invite all of you to think with me, criticize me, agree with me, disagree with me, but then do something to see that we increase the mentorship programs in our country. What I would like to do is talk to you about what mentoring is, and perhaps it is superfluous for most of you. I would like to touch upon how mentoring increases the quality of life of surgeons, the quality of life of surgery in the country as a whole. And being a surgeon in private practice, from the day I started my practice in this country, whatever I'm going to say applies as much to private practice as to medical institutions, be they government institutions or private institutions. So I invite all of you to think with me, and as I said, ponder over this whole concept of mentoring, because it is something that I think we badly need in this country. the overlying fact that we all have to think is a simple statement that the famous American author Maya Angelou made, that whatever we do, people will never forget how you made them feel. That is something mentors and mentees have to keep in mind when they go through the business of surgical mentoring. What I'm going to do is to share with you what I have done in my practice over the last 25 years. I would like to share some of the literature evidence as well, because these are the days of evidence-based practice, and evidence is something very close to my heart. And we did a survey of the surgeons, both mentors and mentees, as the membership of the Karnataka state chapter of ASI. And I'm going to share with some of the results that we got through this survey, which will throw light on what we need to learn and understand about the current milieu of mentoring and the process of mentoring and its attitudes, because that is what decides what we have to do in the days ahead. I would like to start with my salutations to three of my big mentors. Tom Duncan is the man who taught me my first hernia and my first appendix. Yogesh Pai, from Mangalore originally, but a consultant surgeon in the UK, orthopedic surgeon. Unfortunately, he's no more. He helped me crack the then dreaded primary FRCS in the first shot. Thanks to him, from wherever he's looking at us, I'm sure he'll be very happy that he was remembered. Dr. Srinivas is very much with us in Bangalore here. He was the chief of the curriculum development cell of the Rajiv Gandhi University. He is the man who told me that to be an academician, you need not be working in a teaching institution. That simple statement inspired me for 30 years ago, and I have had my stint at academics and have always been completely in private practice. The process of mentoring has to be thought of in very simple terms, and these are two simple definitions available in the Cambridge Dictionary. It is a simple process of giving advice to a younger or a less experienced person, and in a skill-based science like surgery, there can be nothing more important than mentoring. Mentoring is something which is time immemorial. We have seen it mentioned in mythology, the Greek mythology, when the god of wisdom, Athena, takes the form of a mentor to help the son of the then emperor. We are not new to mentoring in this civilization. We know about mentorship and mentoring from the days of the Mahabharata, and the Gurukul system, where students would live with the mentor, with the teacher, learn with him, contribute to every aspect of life in that institution. The Gurukul is something even to this day is relevant, and I would really believe that we must in some modified form maybe adopt this Gurukul system in all our training programs. But the first thing that a mentor should understand is that the primary focus of mentorship or mentoring is the mentee. And instead of spoon feeding him, the job of a mentor is to be a facilitator who helps the mentee, the trainee, to develop his own ideas, develop his own learning methods at his own pace, and develop and blossom both in his professional and personal life. Coming to the survey that I mentioned about, we had 177 respondents. 2/3 of them were mentors and 1/3 of them were mentees. Across the board, I have run statistics on this. There was very little difference between the two groups, between the mentors and the mentees. 99.4% felt that mentoring is a must. For mentoring to work, it has to be supported by 3 strong pillars: trust, mutual respect, and communication. Without these 3 pillars, it is very, very seldom that a program of mentorship ever succeeds. I think among the 3, while trust and respect are perhaps esoteric or a little more diffuse, communication is something that is very practical and very, very doable and very seeable and measurable. We have to be, both mentor and mentee, have to be completely truthful with each other. That is something that every group of mentors and mentees should develop. The Royal College of Surgeons in its guide talks about fixed goals, setting goals for a successful mentorship program. And I couldn't agree with this more. You have to, it goes by the mnemonic SMART. The goals have to be specific. I will teach you doing independently your lap collie. I will teach you doing independently your hernia repair. It has to be measurable. You have to have metrics to say that you have actually achieved it. And of course, it has to be achievable in a limited period of time, which is again, all mentorship programs are defined by a time period. You can't say, okay, I'll make you do a laparoscopic liver resection. You may neither have the case nor the capability of doing it. So it has to be achievable. And in a given milieu, in a given surgical environment, that measure, that goal has to be relevant. And to gain all this, the mentor has to wear various hats. He has to have various aspects that he has to address. It's not that every time he does something that he's looking at himself in these roles, but comes automatically when you start helping your mentee, your junior, in the goals that he has set for himself. First of all, he has to be an educator. You've got to teach him the theory and practice of surgery. You have to be an ideator. You have to make him think and get his ideas out. Ideas on modifications in surgery, ideas for research projects, ideas for writing papers. You have to connect him to various aspects. You need to get him to know a fellow surgeon who does something that you do not do, perhaps get him to another academic institution where they look at projects differently. And you have to challenge him to do better and more each time. Of course, it's a double-edged sword because you can't give him the stress that perhaps he cannot handle, but you must keep him engaged and challenging to keep pushing himself beyond boundaries. And after all that, you have to be a cheerleader. Unless you prep him up, you pop him up and give him encouragement like cheerleaders do. There will be reverses in his career, but you got to tell him that those reverses are a part of the game and that he should not be feeling depressed or low with those reverses. Yes, to do all this, you have to go well beyond the theory and practice of surgery. They are important. They have to know that correctly. But beyond that, you've got to help them with career guidance as well as financial guidance. Particularly if you're in the field of private practice, this is a requirement. Let us look at each one of these and how I have endeavored to help my juniors over the last 2.5 decades, as I mentioned. Yes, they read their exam, they read their textbooks, they pass their exams, and they got to go a bit beyond that. They have to then think about research projects, presenting papers at conferences, publishing papers. And that is one step which many people are hesitant to take, but I think is very, very important for a surgeon in his career. How do we do it? We exchange articles. These are days of information technology boom, so we don't have to really sit somewhere physically. We keep exchanging our articles, full text articles. We have very vibrant interactive journal clubs where we critically appraise papers and we correct their manuscripts, we correct their PowerPoint presentations before they go. We practice it between us or amongst us. It's not just me, my colleagues in my department and all the postgraduates in our department. We sit together and do it. We sometimes Zoom nowadays, we Zoom it and exchange our ideas. And so it's a very vibrant thing where we impart knowledge, and believe me, we gain knowledge as well. We learn a lot from the reading that others do, and it makes our life very much easier. Surgery being a skill-based science has to have a big stress on skills, and this is where hand-holding, physical presence, positive feedback is extremely important in a mentorship program. First of all, you explain to them why you do something the way you do it. That's the theory part of surgery. And then you take them to a skill center and then show them through these processes on the bench. Then you show them in a real operation theater what you do and hand the instrument over to him. You're scrubbed, you're stood next to him, ask him to do it. Ask him to do it. Believe me, after a stint in the skills center, maybe a week, maybe 2 weeks, sometimes maybe even a month, what they do in the operation theater is very much better than otherwise. And we in fact have published papers to prove that. And a stage comes when the proficiency increases, perhaps in 6 months, perhaps in a year, perhaps a little longer, when you may not even have to be scrubbed next to him. You're stood next to him, but that never is not done. You're always there because particularly in private practice, it's your patient. So you're stood next to him, unscrub, but he knows that you're there and you're watching. And nowadays, in the days of laparoscopic surgery, this process has become very easy because all of us are seeing the same image. In open surgery, sometimes the perspectives may change from between the main operating surgeon and the assistant. And sometimes some finer aspects may have been difficult to train. But in laparoscopic surgery particularly, this aspect of standing next to the patient, next to the surgeon, the young surgeon, and mentoring him has become a very easy process. As all of you know, you don't even have to be standing next to him. Today with telesurgery, you can be in some other city, sitting there watching the same image, in communication with him, and you can see him safely through operations that he may be learning to do. Now, coming back to a survey, 88% clearly said that they would like to have the chief or the mentor standing next to them. A little disappointing to me was the fact that 21% of people said that they want to operate independently, which I think is a little ambitious for a youngster, because I personally believe that if you are allowed to operate on your own, you will learn by trial and error, and neither the patients nor the department can afford that error. So I would really believe that all mentoring should happen with this chief surgeon standing next to the trainee. And the concept of graded responsibility has been around from the Halstedian days, from the days of residency that Halsted started. We all know that the amount of work that you give your resident to do on the operating table, even otherwise, even in the wards and the post-op care responsibilities, is a graded thing. And I'm sure over the years, mentors develop that skill and even the sixth sense to know how much they can leave to their juniors. But as I said, mentoring goes beyond teaching theory and skills of surgery. We have to give them career guidance, and that takes the form of further training and placements. No unit can claim that they can do everything. They do everything that is required for the overall holistic training of a surgeon. So it behoves the senior to find people and friends who will be seeing your mentee through those areas of surgery where you're not proficient or you're not having enough numbers to do. For example, if somebody needs an experience in liver resection, I always ask my mentees to go to another, I send them to a friend who does liver resections. And similarly, I don't do any robotic surgery. And if my mentee would like to learn robotic surgery, certainly I would be the first person to pick up my phone, call a friend who does robotic surgery and ask him to see him through, or at least show him the initial ropes of robotic surgery. Placements are very important. This is something that most mentors perhaps may not be thinking about very seriously, but it is important that we take the responsibility after their time with you. I told you mentorship is a time-bound program. So after their time with you, you have to make sure that they're not let loose to fend for themselves. I always work 6 months before I expect my mentee to leave me. I keep making phone calls, talking to him, finding out what he wants, and try and place him elsewhere. In our survey, again, 90% agreed that they would like career guidance. That goes with the standard run of things. And I had a question on ethics, and 95% said that yes, ethics has to be learned from the mentor. But I do believe that ethics is something that you cannot teach, and it has to be lived. And your mentee will keep watching you about your steps in various situations, social, financial, surgical situations, and he will learn from you through imbibition. And that puts a big weight or the responsibility on the mentor to make sure that he shows the correct ethical path to his mentee. Again, a little surprising was that only about 68% said that they would like the mentor to find placements for them. I would think that 100% of mentees, it is not wrong for them to expect the mentor to help them with future placements, because that is very much a part of career guidance. What about financial guidance? Well, if you're in an employment, either in a government hospital or even in a private institution, perhaps you're not worried too much. But you will see from my further slides that a lot of work is done in private practice. And so if somebody has to be eased into a private practice, it takes them at least 3 to 4 years to get into a comfortable situation financially. How do they support themselves in that period? This is something that we have to do. One step behind that, we must talk about stipend for training. We now have areas where training is imparted, but a huge sum, a fat sum is charged for the training. I always felt that we must give them a free training and give them a stipend for it. I have been fortunate to have a salary in the National Health Service of the UK while I trained myself. So I've had the luxury of that. Perhaps we cannot give our trainees a salary, but certainly we would give them a stipend, which is equivalent to that of a third or final year MS or DNB trainee for the 1 or 1.5 years that they stay with me. So we give them a stipend, at least make sure that they don't have to go to some other source for income. And financial planning is something that many of our juniors would not even be thinking about. So I always spend time with them talking about financial planning. What is the kind of income that one can expect? How should they protect themselves? Health insurance, indemnity insurance, and the like, and savings, and how they should go about it. All of it in a very informal manner. It's not that we have classes about this, but between cases when we sit down, we keep talking about it, and we help the people plan their finances. And of course, when they leave you and go away, if they do not have an employment, it gives them some degree of stability. I always tell them that they can always depend on us for the stipend amount of support that they require. It gives them, I have never had to spend money on them because they're all very good, they're very capable, and they earn. But that thought that they are not left high and dry is something which is very, very comforting to them. The next section, I would like to deal with how mentoring helps all the stakeholders. The stakeholders I can think of are society, our patients, the institutions, the mentor, and the mentee. Please note, I've included mentor, and I believe that mentoring helps the mentor a lot, as much as it helps the mentee. For the society, for our patients, the process of mentoring, make sure that you let loose on society a person who is a safe, competent, empathetic, and ethical surgeon. I think that's an extremely important aspect of mentoring. And unless the mentor finds that the mentee is capable of meeting these demands, he should not let him loose on society. The department really benefits tremendously. The fact that you are giving good mentoring attracts very good people to come to you as mentees. So you get highly motivated, efficient, intelligent residents, and it's not easy to find this breed in this day and age. Of course, if you have vacancies in your own department or institution, you will have these known entities. You have trained them yourself, and we have had 2 or 3 very good consultants whom we have taken on in our own departments. And above all, they continue your legacy. After all, what do we work for? We're not in it, as many people have stressed before me, that it's not just the money or the pure pleasure of surgery, but you want to leave behind a legacy. It seems to be a basic human tendency. And of course, a good mentorship will make sure that your legacy is carried out. And what about the mentor himself? Nothing can describe the satisfaction that one gets as a mentor when the mentee performs well as a good surgeon in society. And at a more mundane level, at a more practical level, they do all the writing for you over a period of time. For several years now, they do all the writing, and at the most, I'll affix my signature. It's ages since I wrote my own case sheet or my own operation notes. But yes, it is a big help when somebody else writes and writes correctly. Of course, you correct them and you affix your signature to take the responsibility. You get emergency cover. For how many years after you start your work and you keep on taking calls in the middle of the night? At least the first call, the first screening, the first filtering will occur through a good young surgeon. And of course, if you're needed, you would get up and go and do the needful in the middle of the night. But that first screening and the number of phone calls that my mentees take and give me relief from is enormous. So, and not the least, but the last one is that I learn every day. When a mentee asks me questions, I question myself. And when he asks me things that I perhaps have done automatically, and then I have to go back, find a reference and tell him that what I'm doing is correct. And if I can't provide him a reference for that, I change my methods. So I learn every day. The advantages to the mentee are very obvious. As I've already mentioned, it gives him confidence and he learns the art and science of surgery in a very comfortable manner. This process of mentoring can be formal or informal. Particularly in the West, there are contracts and things like that in mentoring programs, but I have never practiced it. To me, the word of mouth is perhaps more important than a written paper, and all my mentoring has been informal, and I do not think there is a big requirement for any formality in it. Can it be done in private practice? I think it's a moot question. As I've told you, I've always been in private practice, and mentoring has always been one of my habits. 80% of the OPD service and 65% of inpatient work in this country is done in the private sector. So how can anybody expect only the government sector to give us the manpower, the surgical manpower that the country needs? So honestly, is a moot point, and we, all of us in private practice, whether we are individual surgeons or in group practice or working in corporate hospitals or private charity hospitals, whatever the field, wherever surgery is done, I think we should be having mentorship programs. And in my survey, I was a little surprised to find that 30% of our respondents said that it is not possible to do the mentoring in private practice. And in fact, 16% of them felt it was unethical. That's not true. Neither of those honestly is true. There is enough evidence to prove that that's not the case. In terms of mentee feedback, the only negative feedback I have received is that one of them, two of them have said that it is a skewed work-life balance. Perhaps I made them work too hard. And I have learned in the last few years not to drive them that hard. But the things they like.
Sir,
yeah.
Your allotted time is over.
I'll stop in 1 second, in one slide. The thing that they liked most was a free communication, the non-judgmental and constructive feedback, and a lifelong relationship. So in future, I think every one of us must offer mentorship to our youngsters, and ASI would perhaps consider increasing its formal mentorship programs. And we have to learn that particularly in surgery, this is a real requirement. I would like to thank you for your patient listening, and I would like to close this with this beautiful quote from the Dalai Lama, and I give my salutations to Professor K. Krishnamoorthy again. Thank you very much, ladies and gentlemen.
Thank you, Doctor.
Thank you, Dr. Lakshman, for that beautiful oration. I'm sure Dr. K. Krishnamoorthy, your guru, would have been very proud to have had his main and chief mentor or mentee that he had deliver this oration. Thank you very much. On behalf of the ASI, we're very grateful to you, sir.
Thank you very much.
Thank you, everyone.